Hi, this is Dr. Chan Jenbot from Isaac KL. Welcome to BOSS 2021. This is a case of a challenging phakic implant. This is exactly what happened to my patient. He was playing with his son and he accidentally punched his eyes. My patient is a 36-year-old man with a history of right eye sudden blurring of vision of one day after being punched by his son. He had bilateral eye phakic IOL implant done at the age of 21, 15 years ago. He's a very high myope with -12 on both eyes. On examination of the right eye, there's a claw lens that has dislodged inferiorly. The lens is touching the endothelium, causing corneal edema. His vision was 660, but his best corrected vision was 6.7.5. He was also noted to have bilateral immature cataract. This is the specular microscopy of the patient. The cell count on both eyes is actually pretty high, despite having the varices in the eye for 15 years. His lens is a varices lens, which is similar to an artisan lens. Back then, this lens was intended for phakic IOL implant. Of recent years, this IOL was found to be problematic, causing cataracts and reduced endothelial cell count. Hence, it is recommended to remove this IOL if necessary. There are three options: to remove the varices lens and insert an ICL, or to remove the varices and do a phacoemulsification, put in a multifocal implant since the patient already has mild cataract, or to realign the varices lens. Both ICL and multifocal implant will be difficult as the lens is not readily available. After a long discussion with the patient, we have both agreed to reattach the IOL. The first step is to give local anesthesia, which is subtenon. Intracameral lignocaine will not be advisable as this will cause the pupil to dilate. Local anesthesia would be required as it will cause a lot of pain as we are touching the iris. 2 wounds will be required, one in the temporal and one in the superior. I then inject some viscoelastic to form the anterior chamber. It is also crucial not to over-inject the eye as this may push the IOL inferiorly, touching the lens. I now try to recenter the lens with a forceps, pulling it to the center, gently without touching any other parts of the eye. Once it is centered, we have to reattach the claw back to the iris. The most common way to do this is to use a cannula, pushing the iris back into the claw. Of course, in this case will be impossible, hence I use a micrograsper instead. By using a forceps on the left hand, grasp the varices lens to make it stabilize. And with your right hand, use the micrograsper and pull the iris through the claw area of the varices lens. A few attempts was needed as it was not easy to visualize that area. There was pre-existing corneal edema from the lens touch. Care must be taken not to injure any part of the eye, especially the phakic lens, as this may induce cataract in the patient and may cause uveitis as well. After I've successfully reattached the IOL, I wash out the remaining viscoelastic in the eye by flushing out with some balanced salt solution. As the viscoelastic was too viscous, I was unable to wash out all the viscoelastic. I proceeded to use a Simcoe to actually remove the remaining viscoelastic in the eye. As you may have noticed, the pupil is dilating. That is because I did not realize that the balanced salt solution was preloaded with adrenaline. Again, in this situation, we should not be overfilling the eye with BSS and also oversucking the Simcoe, causing the anterior chamber to collapse. Once all the viscoelastic has been removed, I injected the patient with some myostat to reconstrict the pupil again. And I ended with some intracameral antibiotics. This is how the eye looks like on post-op day 1. His vision was 6/12/6/9 with a residual astigmatism of 150, which is similar to his vision before op. This is how it looks like 1 week post-op. The corneal edema has also resolved. Thank you very much. Hope everyone learned something today.